Excision of tumours at the medial canthus with associated excision of the punctal or canalicular apparatus is a relatively common indication for a lacrimal bypass tube, particularly in hot, sunny countries where periocular tumours occur frequently. However, the disrupted medial canthal anatomy, and in particular the lack of normal supporting tissues, provides much greater challenges for Jones tube surgery, as the tube moves medially much more easily and frequently. This video demonstrates one such patient and highlights the challenges and considers some modifications to the surgical technique that may improve the likelihood of success. However, we still find that this group of patients generally have much lower success rates than other indications for lacrimal bypass tubes. This patient has no upper or lower puncti or canaliculi and has post-surgical ankyloblepharon medially. Under the ankyloblepharon is a hollow from tissue loss. A modified endoscopic DCR is done first. Endoscopic DCR and Jones tube surgery is shown in more detail in other videos on eyesurgeryvideos.net. Unlike our standard procedure for normal endoscopic DCR, we are not making a mucosal flap, but rather a small mucosal window, as the preservation of nasal mucosa may help support the tube. Similarly, the bony ostium that you see here being made first with a rongeur and then the DCR burr is relatively small, which may again provide stability for the tube. The medial ankyloblepharon has been divided. There are several options for the location of the proximal end of the Jones tube. In this case, we elect to position it at the carunculus skin margin, as the tissue is more robust here, which may aid the stability of the tube. The tract is dilated and the Jones tube inserted in the usual way, which is discussed in more details in other videos on this website. Various modifications to lacrimal bypass tubes have been devised to try to prevent movement. The modifications that prevent extrusion, such as a flange at the distal end, are not beneficial to this group of patients, in whom medial migration is the primary concern. Frosted tubes and angled tubes have been designed to try to decrease tube movement, but we have not found this to be particularly successful in this group of patients and are using a regular Lester-Jones tube in this patient. When the mouth of the Jones tube is secured with a suture, it is carefully angled and located in order to both be sitting comfortably in as robust tissue as possible, but also to provide a mechanical barrier between the upper and lower lids to try to prevent reformation of the ankyloblepharon.